So the Maintain trial, also called the STEEL NHL-7 study, was designed really to compare 4 years to 2 years of maintenance rituximab after BR chemotherapy for follicular lymphoma patients. As a secondary objective, the STEEL group wanted to do an inter-trial comparison of maintenance rituximab in the NHL-7 study with their NHL-1 study that had BR chemotherapy without maintenance rituximab. The investigators also wanted to look at issues of safety and toxicity, and that's really in follow-up to last year's report of the gallium study that suggested higher than expected non-relapse mortality for patients who received maintenance anti-CD20 monoclonal antibody therapy after BR chemotherapy. So what they demonstrated, overall 4 years maintenance rituximab was safe. They didn't have a significant toxicity or mortality signal with 4 years of maintenance rituximab, so that's reassuring. They also found that there was numerically improved progression-free survival with 4 years compared to 2 years of maintenance rituximab, but that did not reach statistical significance. And certainly there was no difference in overall survival. However, the median follow-up was only 3 years from randomization. So people have spoken a lot about the mantle cell lymphoma subgroup analysis because it was reported as showing no benefit of maintenance rituximab after BR chemotherapy for mantle cell. I think it's really important to understand the differences in that mantle cell lymphoma subgroup. First of all, it involved older patients, so the median age was 71 for the mantle cell patients. And secondly, it was a much smaller study. So only 122 patients were randomized to maintenance rituximab or observation in that mantle cell lymphoma subgroup. And the maintenance was rituximab every 2 months for 2 years compared to observation. So the study was really underpowered to detect in a statistical manner any clinically significant difference in progression-free survival. So the study actually reported an 18-month improvement in median progression-free survival with maintenance rituximab, although it didn't reach statistical significance. But that was likely due to the fact there were only 60 patients in each arm. So if you look at the 95% confidence intervals on the hazard ratios for the outcome of that study, the results of the study were consistent with as much as a 60% reduction in the risk of relapse with maintenance rituximab. So at the end of the day, we can't use that study to say there is no role for maintenance rituximab because it was simply underpowered. So in pretty much every other study of maintenance rituximab for mantle cell lymphoma, there has been a benefit not only in progression-free survival but even overall survival. So the European mantle cell lymphoma elderly study was updated here at this meeting, and Eva Hoster reported improved progression-free and overall survival for maintenance rituximab after R-CHOP. And last year we heard about maintenance rituximab after transplant for young people with mantle cell, and that also improved progression-free and overall survival. So I think we have to conclude there is a role for maintenance rituximab in the setting of mantle cell lymphoma. So in general, they did not find any significant increased toxicity with 4 years compared to 2 years of maintenance rituximab, and that's reassuring after the reports of the gallium study last year. So there was no excess treatment mortality, there was no excess infections, so in general 4 years was well tolerated. So I don't think Maintain would affect our use of maintenance rituximab for responding patients after induction chemotherapy for follicular lymphoma. So those are patients who have achieved at least a partial response to induction therapy and who wish to delay relapse as long as possible because maintenance rituximab improves progression-free survival. They're usually patients who have tolerated rituximab quite well, and these days in Alberta we've moved to subcutaneous maintenance rituximab, which makes the treatment more feasible and much easier for patients. The BRIGHT trial was actually designed to compare BR induction chemotherapy to either R-CHOP or R-CVP. And at physician discretion, maintenance rituximab could be used. So it's important to know in this analysis that was reported at ASH, the assignment to maintenance rituximab or observation was not randomized. So as such, there were significant differences between the groups of patients who received maintenance rituximab or those who did not. For example, after BR chemotherapy, the patients who received maintenance rituximab were less likely to be in complete remission compared to the no maintenance rituximab patients, but were also less likely to have elevated beta-2 microglobulin levels, which is an adverse prognostic feature. So we need to take these results with a grain of salt because they weren't randomized. And what was reported at ASH was simply a comparison of progression-free and overall survival for those who received maintenance rituximab versus those who didn't. And there was statistically significant improvement in both progression-free and overall survival with the use of maintenance rituximab. But unfortunately, the investigators did not perform a multivariable analysis to control for these potential confounders. So we don't know from this study whether the benefit of maintenance rituximab would hold up in a multivariate analysis. Again, the encouraging thing is they really did not see any safety issues with the maintenance rituximab arm. It was pretty well tolerated, and they didn't see excess non-relapse mortality.